Okay, so the next person is, you prefer Victor to Dick. Oh, sorry.
Wrong one. Wrong one.
Too many on this. Okay, history.
Yep. Okay, Victor, my age is 66, and I had a fall down the stairs, so I have a 12 millimeter tear in the right shoulder and a minor tear in the left.
How did you land?
Well, I was trying to stop myself from sliding down.
Okay, how did you do it?
So I put my arms out to try and stop myself.
Okay.
And my range of movement starts to get limited from about there.
So when you're falling, I'm more after the dynamic of the fall.
Yep.
So when you're falling, did you try to grab anything to stop yourself?
That's what I did. I slid that way.
Yeah.
I put my arms out that way to try and grab the banister. And
and that's probably how you tore it.
Yeah.
Okay, because his whole weight is going downhill, and he's trying to pull himself up.
Okay, stop. Yeah.
Okay, stop. Yes. So, all right. Did you have any imaging done at all?
Yeah.
Okay, which one was torn? Bet you the
right
supra.
Supra, yeah.
Supraspinatus.
Yeah. 12
Did you do any of the other ones?
No.
Because on that one, you're lucky you didn't do any more, because you would have moved the shoulder blade very acutely, which means you could have done your subscapular muscle as well.
Well, yeah, but it's a supraspinatus 12 millimeter tear.
Yeah. Okay, full thickness tear or partial?
It didn't say.
It didn't say. All right, let's assume that it's a full thickness tear.
Yeah.
So anything else you want to ask him? How long ago?
A month and a half.
So quite recent.
Yeah.
Still very recent.
Oh, yeah.
How much pain are you getting out of a range of 0 to 10? 10 being absolute pits.
Yeah, it's generally between 5 and 7, depending on
so when it's good, so if it's good, if it's really good, any pain at all?
When it's good, it's really about a 5, but in the mornings after waking up, it's quite stiff and range is really bad.
So you go from 5 to
7 or 8.
So there's quite substantial pain even at the best of time.
Yeah, even sleeping, it will wake me.
It will wake you up.
Yeah.
All right. Is that enough history for the time being? We're just looking at shoulder.
What happened to the left shoulder?
That was doing the
because it spread out both arms.
It's a lesser tear on the left, but a 12 millimeter definitely on the right.
All right. Can we just go through some of the I do a very abbreviated examination. I don't go through the whole lot of the shoulder examination. I think this one is quite adequate already. Can I get you to just horizontally up? So he's got quite full one, as you can see, and we usually measure the degree here. All right. Have you got it in your?
Hey?
No, they all register how far it is. Come back down halfway. Can you bend your elbow and bring it back? And he's tight. These are not happy. Go straight across. That's not bad. So his acromioclavicular joint is intact. Because if that's involved in any way, he won't be able to do that. All right. I won't put him, because one of the mistakes we always do when they got this is trying to put them through all the full movement. They can't do it. So I just do it, like I say, a very abbreviated examination. All right. Have you all got enough information on that one? Now, can I get you to do this other arm? Straight up. So he's not very flexible. This is not very far off the other side. A little bit better, halfway. Bend, back. And he's a little bit happier with these ones and across. You're more comfortable with that one. Okay. Now, with an injury like that, we always look at the neck as well. And just very quickly, do a neck movement side to side first. Turn side to side. And straight across. And down. And he's quite good on that movement. Passable, all right? I'm going to do the examination next. Do you want to do the examination next? Sorry.
Harry.
Push him away.
You want Harry?
Well, can we get the next couple of people up to feel?
That's right.
You, one, and one more. 2 person. You want to have a quick feel? No? All right. So stand over here. So we'll have a quick look at you. So can I have your hand? Are you sore in any side? Very minimal. It looks pretty good. In fact, this one feels more than this side. Although this is your worst shoulder, wasn't it?
It is, yeah.
Yeah. So just relax that again. Yeah, this side is still slightly more than the other side. Have a quick feel. There's slightly more tension on that side than this side.
Yep.
Have a quick feel. So we're going to start off with the elbow diagnosis on the side that's a little bit more intense. So let's have a feel of the basal ganglia first. There's a bit there. I can feel that flicking there.
Yeah.
Go ahead. It flicks under your finger.
Yeah. Roll.
Roll it.
Oh, yeah.
Okay, you feel that? So the next one I feel is for the cerebrum, which is inside, and it looks quite okay. Cerebellum on the outside. I think that's possible. Neck, a little bit, very little. The neck is actually quite substantial. Now, if I'm looking for the shoulder, I come down a little bit. And I think that is even more sensitive.
Yeah, you can feel that.
Okay, so if you look at the line itself as being the neck, come down a little bit to accommodate the shoulder. You can feel that actually quite tight. Go ahead. So bring down your feet. This is on the neck. So bring it down slightly, just about 0.5 centimeter. Sorry, too much. Lighten up. Okay. Can you feel that flicking?
A lot of tightness.
Yeah, a tightness.
Yeah, a lot of tightness.
Can you feel that? So that's the neck.
Neck and shoulder.
Yeah, neck and shoulder. And thoracic is quite okay. You've got something a little bit on the back as well, but we'll leave that alone. All right. So the same on this side. This is his worst injury. So if I feel for and that's positive, just like the other side. Cerebrum, a little bit too.
Yeah.
Cerebrum is also a slightly positive. Cerebellum, that's quite okay. The neck is involved. This neck is actually more than this side. Shoulder, yeah, definitely. This one, the shoulder is quite intense there.
You can just see it.
In fact, you can see me as I'm rolling.
Just that full resistance.
Yeah. And this is a thoracic and lumbar. So that already completed that one. We can go back to the neck and see what else we find on that side and then onto this side. Okay? So once again, I look for the kidney. And as I drag it out, you can find that on the outer side towards the shoulder, the upper part of the body, that's positive. And if we go down the bladder, liver, not too bad. There's a little bit there. Pericardium. Is that a bit sensitive at all? Pericardium? It feels quite okay to me, actually.
Yeah, no.
Heart, gallbladder, small intestine, large intestine, triple energizer is positive. Stomach, spleen. And you can do the lung there. So I'm coming on to this side where most of his major problem is. Kidney. You can do the spine next if you like. And as I come out towards there, once again, not as actually intense as that one on the neck. Bladder, liver, All right. Pericardium, heart, gallbladder, small intestine, drop down, large intestine, and I think you've got a positive large intestine there. Yeah, because of that. Yeah, that one. And triple energizer is also positive. Yeah.
Yeah, because when this pains, it'll come down there.
That's right. So it correlates well with the symptom. Stomach, spleen, and I think the lung should be quite okay. Okay, that's the lung. All right. We've done the elbow diagnosis and the neck diagnosis. We've got a few things that's going to help us there. So should we start treating? And then you can see what happens to the points when we treat it. This is yours, okay, 3. Just remember that 3 needles will come out. Yeah, you can put just you have to remember how many needles you got, that's all. I'm fussy on counting because, especially in a patient who can't feel, all right? If you leave a needle there, it can be quite drastic because, especially on the back, and if it's somebody who is wheelchair bound and all that, you put the needle there in the back, it just migrate. Disastrous. So you must always count your needles. Okay, so if we're going to start treating, I can treat either the left or the right first. I think seeing that this is more his problems, shall we do this side first? Okay? So he's got the cerebellum, is that the right and the left, isn't it?
That's right.
So this is right side. So we're talking about his cerebellum being sensitive. So if one of you can come across here and just find the cerebellum point first and see if you can identify the cerebellum being tender. Cerebellum is on the outside of the biceps.
Oh, yeah.
Can you feel it now?
Yeah.
All right. Keep your finger there. Don't move it.
Mm-hmm.
All right, just move in a bit. Okay, got it. Has that changed?
Yeah.
It's changed. You see, without even the needle, when my finger there, it changes already.
Yeah, just your nail
Now
pressure.
it's like,
Yeah. Just trying to see what I'm doing.
definite harmonization. there.
Change now?
Yeah, it's more
Softens.
harmonized.
Softens. Even he can feel the softening. The next point, what we want is the shoulder point. All right. So if I'm going to go for the shoulder point, I might actually go for the J-somatotope. I love J-somatotope because it's just so simple. So if I'm looking at that, I'm on the neck here. My shoulder should be coming down here. And I think I've got you there. Okay, that's it. Right on. Can you feel me there? Okay, how does it go?
Softened.
Soften? Let me see if it's gone. No. No, it's not all gone yet.
No.
I might need some of the other 2 points for it to go away. So let me do the other ones first. Can you feel that? It's still there.
Right.
So if I'm going to go for this 2 channel, I can either take the cranial nerve or I can take the epsilon point. Where's the large intestine? Remember the small intestine drop down to the large?
Yeah.
It's round about here. And like I said, it's not a nice pointed needle. So I
better
tend to go for that one. And it's a CN 12.
So would you get the same feeling there?
Oh yeah. Let me see what we get when I touch it, okay? Okay, I got it. What does it feel like?
It's softening.
Has it softened?
It's softening.
Okay. Let me have a look. Oh, yes, it's a lot softer. Feel that now?
Oh, that's so
Emily,
different.
if you did
So
needle the gallbladder point, how would you do that?
Gallbladder, I tend to take it up there as well because it's very sensitive here.
So you never ever needle that?
I do needle there if I find that this might be more sensitive, but a lot of patients don't like that point.
But if you are needling here, how do you need the needle?
I usually go at that angle, 25, at the most 25 degrees again. How does that feel? It's the last of the cranial nerve. So we just use, you can arbitrary line anyway. 1 centimeter from the midline is a cranial nerve. Behind the A point, remember A is starting inside the hairline. Approximately as about 1 centimeter up from there is where the start of the cranial nerve is. And usually I bring it right back to almost the apex, where the apex goes, almost to where you get the GB20, around that line. Okay? And then you just divide. So that's number 12, virtually on that line. The next one I want is those two, large intestine, which I've done, and then the triple energizer, just to stay with the cranial nerve. What number is that? Adducer nerve, number 6. So if I want to do here, I'm just going halfway there. All right, or you can do it over here. So let me find it first. And you got the tender spot there. Quite easy to feel. You have a quick feel it. Where my finger is, you can feel it, the difference. An indentation there.
So that spot's an indentation?
In his case, there's a bit of an indentation there. Can feel that? You have a quick feel? With all you rubbing on it, I'm sure you've given him a treatment already.
And I think you can feel the glow.
You can feel it, isn't it? As we,
Yeah,
because,
it's a warm glow.
yeah, that means the circulation is going through. There it is. So if I want to check this, it's very different.
Oh, okay. I didn't feel it before there.
You didn't have a feel. Did you have a feel in the neck early on?
No, they all did the elbow.
It's softer? The sunjab is softer at the neck?
Yeah.
Okay.
Yeah, then you check the range of motion.
Yeah. Just very gently, can we see you move this arm up now?
Oh.
I think that's a lot further
Yeah.
because we could see his ear early on. In fact, this might be better than the other side now. Bring it down.
Cross.
Yeah, this was no problem anyway. It's this one. And he has actually improved even on that one.
There's no real grimace there.
Yeah. So that's it. Oh, you can fix it. You got nice friends. Okay.
And how's the pain level? It was 6
It's reduced. Yeah.
You want to give them a figure?
Yeah, oh, it's reduced by half.
Okay,
It's
reduced by half.
Just doing that.
It's a lot easier, isn't it?
Easier.
Yeah.
Yeah.
So we only got 4 needles in. That's it. Don't need a lot if you hit it right. All right. Let me have a quick look and see if we just give this a little bit of a treatment as well, okay? Actually, this is already responded.
Yeah.
Yeah.
Has responded to what we are doing on the other side already. It's less. It's still there, but it's less.
So, I mean, how often with chronic tear like this is going to take a long time?
It is. Usually when he's got a chronic tear, luckily he seek treatment or he has given himself some treatment early, which means his healing time, I predict, will be less than the 1.5 years that I mentioned.
Yeah.
Usually we tell patients, it's 3 years if you don't do anything. Half the time if you do, so it's 1.5 years. So you look really good when you reach there before that time. So you should reach there before the 1 year is up, I think.
Hopefully.
Yeah. You know what you should and should not do. The problem is when patients try and attempt to keep finding the pain and they keep increasing. It's a bit like picking on a sore. They never let the sore heal. But I'm sure you're more sensible than that.
How many times did you say you wanted to see him?
I will see him on a once weekly basis until we get a lot further. If he's good, we can go a little bit further. So the patients that are non-compliant, I tend to bring them back more often.
Would
You can't
use
trust them.
any supplementary points?
Well, you already actually reduced a lot because I thought that you might not respond to this movement.
Yeah. Oh, this year.
And which will mean that this is tight. And normally I would have added in a pericardial point, which would be this one. Okay. But I didn't need to because he's already responded to the other ones. So it's a KISS technique, okay? KISS technique. That's right. Keep it simple. All right. So this side, I'm just going to put in 1 point because there's still a little bit on that.
Yeah.
On the left hand is the vertical or
The shoulder one. And then we'll let you go and sit. We're going to leave the needle in just for about 15 minutes to 20 minutes. You time it yourself and then just get somebody to remove it for you. Okay? Take them home. I just think how many people you're going to freak out.
Not my problem.
Not your problem. What if they faint on you? Are you going to, is that your problem? Not your problem still. Still there. Doesn't want to go away.
It's stubborn.
Not that's better. I think I've overdone it. Back. Still there, you know. You do need that one.
Yeah. I was going to say, I think you need an extra point.
The left side, you haven't got TE. But it's not the TE that I'm after. It's actually the pericardium that's positive.
Yeah, I think it's pericardium.
It is a pericardium that's positive. So let me put in the epsilon pericardium point. Yeah. And I think you can feel me there. Yeah, gone. Okay. So that's pretty good.